We have 4,000 physicians, almost 10,000 nurses, 250 research facilities. So it's a high functioning, complex, dynamic, hyper functional organization, on a normal day. And then, when it gets pulled into this disaster zone, that's where we come in, and the overlay of emergency management and how we enable effectiveness during a crisis like this, I think is my story. But again, so we saw the job and in January, and we activated this thing on the 26th of January. That was when a lot of people, not only in New York, but everywhere else, were talking away the job. They were saying, hey, it's different in central China, right? I mean, those people, they're heavy smokers. They eat live animals. I mean, that's not going to happen here. But we have a lot of epidemiologists that are really world class, and they couldn't understand they didn't see any real reason why this novel virus that people have no immunity to, why it wouldn't emerge in New York when there were 5 direct flights from John F. Kennedy Airport to Wuhan, China, and we had the largest concentration of Chinese people in central Brooklyn. Why would we not expect that outbreak would occur here? And of course it did. But for us, we spent all of February really dragging this enterprise into the disaster and convincing that it was going to happen, and taking action, activating the organization to act. That's what we do. We want people to act, and act today. And so we spent a lot of February getting ready, and we had our first case on the 5th of March. And that was actually in our Mineola Winthrop Hospital out in Nassau County. Shortly thereafter, followed by obviously these cases everywhere. But the job was different than we expected. We expected a flood of people inundating our hospitals, but the difference was that this government lockdown, and it kept people in their homes, and so the city was transformed. It was transformed from into a ghost town overnight. It was eerie. It reminded us of 9/11 when the streets were empty and it was quiet, except for the ambulances. And as people got sicker, they started to call 911, and those ambulance runs just started to climb, and they went from 4,000 to 5,000 to 6,000 to 7,000 runs. We broke all kinds of records with EMS runs in March and April, and these were all coronavirus patients, because all of the other patients stayed home. They didn't want to come to hospitals, and we're still seeing that. So the patients started to come in, and they were already sick, and they got sicker, and they came into the emergency room struggling to breathe, and many were intubated. We intubated 300 patients in the emergency department here at Tisch Hospital in one day, and that was a similar story at all of our hospitals. And these patients were very sick, many of them on ventilators for a week, 2 weeks, 3 weeks. And the other thing is that they had no family with them. We are not allowing visitors into the hospital. And so they came in and they relied on us for everything, not just patient care, but, communication, sometimes even life decisions. And so they were very heavy burden, and we got thousands of them. And many of them, the death rates were high. We had hundreds of deaths in these hospitals. And so our fatality management processes we had to reinvent them overnight. And even now we have refrigerated trailers outside our hospitals with decedents there. And the city is just inundated with the dead now. It's just been overwhelming. But that's as I said, so March 5th, the first case, and we saw that trickle turn into a river, and we watched those flood waters rise, and we didn't know how high they were going to get. We didn't know if we were going to drown. And that was really the fear. I think all through March and into April, we didn't know how bad it was going to get. And, we were looking for that apex. We were looking for the top of the job. And there was a point in some hospitals where we didn't know where the next 10 patients were going to go. But around the 9th of April, it was a milestone. Things started to turn, and we we didn't hope, we didn't want to hope that it had turned, but it had. And so now the last 3 weeks or so, we've started to climb down, and we're still there. Our hospitals were transformed overnight. We had a lot of coronavirus areas identified, but as those patients streamed in, they essentially filled up, and we turned over our floors, sometimes 1, 2, 3 floors a day into coronavirus units, and we filled up our labs and our operating rooms, in some cases our conference rooms, just all filled with these patients. And it was so it's been kind of a wild ride, and now we're trying to figure out how to sort of climb back down.
Okay.
Susan, are you there?
Yeah.
Susan, attendees aren't getting sound. Your microphone's on mute.
Just tell Kelly, keep talking.
So, it's about 2 minutes till, so I'm going to start walking. I'll show you again. Here's our EOC. We have 3 of these. We have one at Winthrop, and I'm going to turn the camera around and talk a little more, but I want to walk outside. I hope you can see this, and I hope people aren't getting vertigo. But, this is something I think that, if there's been one group of people that have been affected by this, it's been our nurses. What an human being. And, the people talk about, nurses getting upset and walking out because of this or that. And that doesn't happen with the nurses I know. A nurse doesn't allow a patient to not get cared for. A nurse is going to make sure that patients get cared for, whether it means that they sacrifice their own health and even their lives in some cases. So, and they've borne the brunt of this. And I don't think we understand what those impacts are right now. And but they've been getting crushed. And this is a great tribute to them in my mind. So I think you'll see it. This is our lobby. This is First Avenue. I'm going to walk you down.
Carrie, we've got a question. Yeah. Somebody's asked why there was a change on the 9th of April. How did you reach the apex?
It's interesting. We don't know. I mean, that river, it just turned, right? And we don't really understand why. But so it's going to get noisy. I'm just going to walk you through. I'll probably stop talking for a few minutes and just show you this.
Okay. Kelly, the camera's not working so well outside.
Susan, what's that?
The camera's not working so well outside.
Yeah, I'll walk back. Did you get a sense of that?
Yes, absolutely. And that obviously makes all the healthcare workers feel very valued and acknowledged.
Yeah, yeah. And it happens not just at the hospitals, but it happens everywhere. And so I will walk back in. So I'm now in the lobby of Kimmel Pavilion. This is our new hospital that is also been transformed into essentially a respiratory intensive care unit here. So I don't know. That's kind of my whole show, Susan.
Yeah, I've got two questions. Where are the other two EOCs you mentioned? Are they staffed 24/7 and are they operating virtually of staff on site?
They're all on site and they're 24/7 and one's in Brooklyn, in our hospital in Sunset Park, Brooklyn, and the other in Mineola on Long Island. So we have one here in Manhattan, one in Brooklyn and one on Long Island. And, you know, we are here. We have been here, and it's, you know, when you do emergency management, you have to work across the organization from the tactical level at where the nurse is providing patient care all the way up to, you know, the C-suite and the strategic level. You have to be able to work across those, and that means that you can put eyes on things immediately and bring all of the resources to bear on a problem. And that's really what we do. Is we do what we call incident operations, which means we speed everything up. And so in February, you know, we had weekly calls. Then when we had our first coronavirus case, we transformed that to daily calls. So we went to a 24-hour op period, which means that everything is sped up. And then at the peak, we were having multiple calls all through the night because we were changing our processes. We were changing our workflows in real time. If there's one sort of term that defines this incident, it's pivot. We pivoted when the disease presented itself. When we learned things about it, we pivoted on our approach. We pivoted on our precautions. We pivoted on our PPE and who wears gowns when, and we transformed the hospital. We changed space. You know, the dean's conference room that no one could ever could be in unless you were approved to be in. We turned that into a face shield factory in about 6 hours, and we built 50,000 face shields out of that thing using medical students. So you do things that you never thought you would do, but you have to move quickly.
Okay, Kelly, I've got quite a number of questions coming in now. A question from Tim Webush. When the surge commenced, what new practices, for example, external triage points or similar, did you need to implement, and what were the challenges with this?
So that's a good question, and it really had to do with how we triage those patients at the entry point. And the challenges of this surge event are always the same. It's space, staff, and stuff, and it was really about space. And I walked past a tent that we built. I could show it to you again, but we built tents external to our emergency departments as those triage points. And so because once a patient enters your emergency department, you have a duty of care to that person. We wanted to make sure that somebody that was presenting who wasn't ill wasn't going to occupy the ED and take those resources away. We could triage that person. We we could point them to virtual urgent care or some other resource without them filling up our hospital in essence. So it was about space, creating that external space.
So another question, Kelly, did you come up against any resistance or reluctance in your perceived resistance in your early activation? And if so, how did you overcome that resistance?
I mean, it was a total denial by everyone, and you know, so I've been in this business a long time, and I talk about the brick wall of hope that people walk around with, and you know, they see the disaster, and there's a brick wall in their minds, and their voice is telling them all of these reasons why it won't happen, and they believe that voice. And then when the job happens, they turn around and say, you know, why was I duped? Oh, when I should have known that this was going to happen. So this is really our job, is to convince people that the disaster is going to happen ahead of time. And it took a lot of convincing. I remember some very heated meetings with our senior leadership. Not all, many were bought in, but some weren't. And there was a lot of skepticism, especially in January, obviously, right? Because again, everybody was saying it's not going to happen here. But we persevered, and you know, there was a lot of data, and there was a lot of good evidence from the epidemiology side that it was going to happen. And then, but I'll tell you, as soon as really government got involved, as soon as the city was involved in the state, and they started to talk about the modeling that they were seeing that was worrying them, and you could see those, you know. Here we have a mayor who's a proactive mayor, a very proactive governor, and they have these conference calls every day. You could see sort of the fear creep into their voice as they saw those models, because as bad as this incident was here, the models were actually much, much worse. I mean, the things that they saw in the data was so scary, and you know, thank goodness we didn't have to encounter that here. The water came right up to our necks, but we didn't drown.
I've got lots of questions here, Kelly. One is, can you talk us through the changes in spaces and creation of physical beds?
Yeah, we created, so this hospital, Kimmel Pavilion, we spent 9 years and we built 350 beds in this hospital. Over a 2-week period in March, we built 700 patient beds in 2 weeks. So, and that's the difference, you know, that's the difference is we begged and borrowed and bought everything we could get our hands on to create those staffed beds. As you guys know, it's not an easy prospect, especially the staffing part. The staffing part was the hardest. The nurses, you know, we became essentially an ICU. All of these hospitals are ICUs. That's a 1-to-1 patient-nurse ratio, and it's a very difficult ratio to make work, especially when these patients are so sick.
So where did you get the staff from?
So we didn't get them for a long time, and these staff, this chair I'm sitting in, you know, was a bed for many nurses on many nights, and they would catch a few winks and they would get up and they would go back to work. But we finally started to get some travelers in and get them a break. And I'll remember when that happened, boy, that was really a turning point when those nurses started to get here.
Okay. Another question from you and Wallace. Are ICU beds and patient allocation managed centrally, anywhere, or separately by health services?
No, they're all managed by us centrally. This place is a technology-rich organization, and they know the status of every bed across the entire system.
So excuse me, so what you mean is Langone Health managed itself. It wasn't
correct.
It wasn't all of New York approach.
Correct.
Okay. Somebody has asked, Amy Morgan's asked, is the New York experience documented anywhere? Can you recommend resources?
It's not.
And I'll tell you, Amy works for ESTA, which is the emergency 911 call center.
Yeah. No, I think, that we're still in the job, and that is part of what we've been doing, is pushing people to start to document and look back. We're still living day to day. In the peak of it, you're living hour to hour, and now I think we're day to day. It's even too soon to sort of look ahead. We don't know what the new normal is going to look like, but we're not yet looking back and documenting. And that's a problem, because we're forgetting, and a lot of things we're already starting to forget. But I wish there was more documentation, and that's something we're trying. Just this week, we're really trying to push.
Okay. A question from Melissa. Are you doing anything different in preparation for a potential second wave?
We are keeping everything that we got, and we are also looking at the processes we use to transform, all of these units into coronavirus units, and we're trying to really figure out, is there an algorithm for that? How do we create a plan around what happened? But it's a little complex. We have 4 different hospitals that we did it in, 4 different, very, very different outcomes in those hospitals. They were different neighborhoods, different patient populations. The fatality rate in Brooklyn was significantly different than it was anywhere else, and that was where that Chinese population was. But I'm not a clinician, and I'm not a scientist, so I don't speak with any credibility about any of this, but I'm just saying that we're going to keep what we have and not let go of it until we're sure we won't need it.
And here's the question that I knew you would be asked from Stuart Krelt-Simons. What was the most significant welfare well-being challenge that you came across for those managing the emergency? What is the one bit of advice you would give us?
For us, for the managers?
Yeah, well, yes, for those managing the emergency, yes.
Siusan, I mean, you and I have talked about this. I think that, in New York, we are far behind the curve on this, in spite of the fact that we've been through so much here. I got into this business on 9/11, and I've been through so many disasters, and we still are abysmally bad at really addressing those wellness issues. And we're learning a lot from you and what you're doing there. But there's a lot of resources available here. There are focus groups, and there are one-on-one counselors in person and on the phone. But it's really there for people. But I think you have to sort of almost force people, or at least draw them into that. And I don't know that enough of that is happening. Although I will say, I'm not in those nursing units, and so I'm sure those individual managers are pushing that.
Have you made any reformative changes during this response that you'd like to see maintained ongoing?
I think that the collaboration, the way this organization broke through those silo walls and worked together as a team in such a cooperative way, the conflict was really minimized. The politics was minimized. You see this only in the worst disasters, that really a lot of the politics just melts away. And that I see that those politics and the turf wars and the personalities creep back in. That is one of the benefits. You can really move a mountain in the midst of a job, because everybody's working together and nobody says no, and we're losing that. But it's inevitable, right? We're getting back to normal.
And somebody's asked the question, how many staff have you lost?
I don't know the answer. We've certainly lost some, and I know personally several that we lost. I don't know how many in total, but we've lost nurses and doctors and security officers and building services workers.
And I guess the hospital hasn't, you just haven't got a moment to pause to recognise those losses at the moment.
That's right.
Yeah.
That's right. I don't think there really hasn't been any reflection right now. There's a couple of things that happened in this lobby. 3 days ago, we discharged our 1,000th patient, and she came right out these doors. And you know, this organization is it's an amazing place, and you know, but there's a, like, right now I'm talking and I'm talking loudly, and it's a very, people like it to be quiet here. But when we rolled that 1,000th patient out, people were screaming at the top of their lungs because the emotions were coming out. And it's a really amazing video. You can see it online, and I can send you the link, but it was such an emotional moment because of what we've been through. And you know, but it wasn't really a reflection. It was just this collective recognition of what we had all gone through together. And the fact that it was, you know, that it was a happy moment. You know, we were letting that patient go, and she, you know, it was an interesting story because she's very independent. She didn't want to come to a hospital, but the care she got was so incredible, you know. And that's really, I think, the thing here is that everybody here gives just tremendous human patient care, and that's what the value that I think we bring.
So you were talking to me privately about the nurses, and you mentioned them briefly as you were walking out the door before. But what have you found has been the biggest well-being challenge for the nurses?
You know, they have had to connect the patient to their families to say goodbye, essentially. You know, they many times they, so this is a respiratory disease, and you labor to breathe, and the energy that it takes to breathe is actually works against you. You can't get well because your body is trying to breathe, and so that's why you intubate, and that's why you put people on ventilators. And that decision is a tough decision because the ventilator will take the energy that it takes to breathe on and allow the body to heal. That's the concept. But when you make that decision, you have to tell people, have to, in essence, say goodbye. And so they've been at the bedside holding a phone just like I'm holding it now with a patient, saying goodbye to their families. And that, I think, was the hardest part. And that's been happening thousands of times around the hospital. And, you know, I don't know that a nurse really bought in for that. You know, I mean, that's something that's, nobody even talked about them having to do that. It just happened. And then it started to happen, you know, dozens of times. And I think, you know, the nurses are like, you know, I don't have a choice. And they talk about, you know, I could go in there and sit with someone and hold their hand while they passed, or I could go and, you know, take 5 minutes and get off my feet. You know, the decisions were very tough for them. And, you know, so you have a nurse that's giving everything that she has, and yet she's feeling guilty about it at the same time. So those are the kinds of things I think that, you know, it's hard to bounce back from that, you know, and so there's going to be a period now where we're going to have to figure out how to rebuild some of that.
What about, I talked in my introduction about the non-direct patient-facing people that have passed away in New York as a consequence of this. I mean, how do you feel coming to work every day? You're
so,
coming
you know,
into...
I knew that, you know, I'm 58 years old, and early on, you know, I knew that I could get sick and I could die. And I'm not saying I braved death, but it was a reality that we all lived with. And but you know, you basically have a job to do, and this is the nature of. I'm not a brave firefighter. I don't save. I'm not a hero, but you know, you do your job. That's what everybody goes back to. You know, I just had a job to do. We all had a job to do, and you know, my team has been here every day for the last 94 days straight. I mean, actually, tomorrow morning at 7 a.m. is our 100th day activation day. So we've been on site for 100 straight days, and you know, but that's what we do. You know, that's what we do. And, you know.
Okay. What was the key thing you needed that surprised you, that you didn't know you would need during the climb to the apex?
So we thought a lot about the upstream stuff. We didn't think about the downstream stuff. We didn't think enough about the implications of having 600 patients on ventilators in one hospital, because there's lots of supplies and equipment that go with that. You need, a lot of cases, you need dialysis machines, and you need feeding pumps, and you need compression pumps, and you need, we got to a point where we were running short on sterile water to moisturize the air in the ventilator, because you have that in the hospital, but you have it for a dozen patients. You don't have it for 600 patients, especially 600 in 3 different hospitals. So those all of the things around a ventilated patient for 3 weeks became very, very scarce, and we were hand to mouth. We were getting things off the trucks and running it up the stairs. And in some cases, we're doing that with gowns to an extent. We're really hand to mouth with isolation gowns. We go through 25,000 isolation gowns a day.
Okay. Somebody has asked, John Toda has asked, what is the coordination process in relation to the 3 EOCs across your hospitals? How do they link with each other? And how do they link into city or state level coordination?
Yeah, that's a good question. And these disasters become the nightmare of the conference calls, right? So we start our day at 7 o'clock with the SME call. That's the epidemiology call. That's where we understand what's going on with the virus itself. And then everything just really evolves from that. We have an internal, what we call a sync up call at 8 o'clock with all the EOCs. And then at 9 o'clock, we have an enterprise call. That's the entire organization all together. We all understand the job in the same way at the same time every single day. And then that 9 o'clock call is really the main point. And then at 9:30, we break off, and then we get into our campus calls, right? And we have a main campus call. And so so we start granular. We start with the virus. We work our way up, and we talk, strategically, we talk about the enterprise, and then we go back and talk about individual hospitals. And then there are the huddles, and that is really the key, is that, we get that situational awareness, we understanding, we bring it to the enterprise level, and then it has to come back down. It has to come from the enterprise level back down to the nurse on the floor. And that's the biggest challenge. And, we never really got that right. In the midst of the crisis, people aren't reading. They're not listening. Unless even when you're talking face to face, sometimes it's garbled. It's amazing the chaos that is in people's minds. So the messaging was the most difficult thing. And so you're trying to message in the midst of chaos, and you're trying to change workflows. These are workflows that have been perfected over weeks and months, and now we're changing them every single day. So the challenges are enormous.
Mm. And what about linking into state level or city level?
Right. And so we link to the city every day. There's a city call. There's actually 2 calls. There's one which is just a healthcare call, which is an ESF. We have an ESF 8, which is an emergency support function, which is part of our incident command system, MIMS, which is our national incident management system. So we have an ESF 8 call at 11 o'clock in the morning. And then there's also a hospital call, which is Greater New York Hospital Association, which is really the CEOs talking. And that comes really, that's in concert with the state. The state is the regulator of hospitals here in New York.
Okay, so there's a question here which I'm not sure you're qualified to answer, but where are the next hotspots in the US? Like you talked about your 4 hospitals having different population groups. What are the next hotspots? And it's from afar, it sounds like there are many places still unprepared or even rebelling against restrictions. Is there confidence in the system response?
Yeah, that's such a great question, and you're right. I'm not qualified, but I would say, as I understand it, the only place in America that the curve is trending down is in New York, and everywhere else it's still creeping slowly up. And so, and yet there's this tremendous pressure to open back up again. And it's a very political crisis here, like I've never seen before. And there's just no telling where it's going to go. I mean, you know, we are now prepared for that second wave. And now that we've been through this first wave, you know, we're not afraid anymore, you know. But if I was in you know, New Orleans, or if I was in Chicago, or if I was in San Francisco, I don't know that I'd be so confident.
Okay. So this is a question from someone you know, Kate, Kate Siebert. You
Hello,
mentioned
Kate.
New York is in lockdown. Have you got any sense when restrictions will start to ease, particularly to juggle the economic sector pressures?
Boy, that's the question. And, you know, we thought mid-May, but now it's looking like the end of May, and then it could be longer. But, you know, I mean, I've been in this city for 30 years, and it is really, it's just even beyond what we're seeing after 9/11. 9/11 was my catastrophe, but the economic catastrophe that's unfolding now is going to go well beyond that. And I don't know how long any of us can stay here. You know, I mean, you see all these office buildings, and all these people used to get on a train at 6 o'clock in the morning to come in and sit in a room so that they can work remotely with somebody in another city. I mean, does that make any sense? I think these office buildings are going to start to empty out. People are going to see, they're going to try to wonder why they ever came together in a crowded place like this to begin with. And it's really the catastrophe behind this catastrophe, I think.
Okay. Is there something that you wish had happened sooner, or something that you'd like to see now? What do you wish you'd done sooner?
I mean, everything, I guess. If we had moved up, you know, building our external spaces and transitioning our units. I think, you know, obviously if I had the benefit of hindsight, we would have transformed those floors, many, many more of them than we did. Instead of, you know, 4 units, we would have just went ahead and turned the whole hospital over, right? And we know now we needed it. But nothing really sort of leaps out, and I think it'll probably come when we get into those detailed discussions, after action discussion.
Well, this question is a little bit similar, and it says, you know, if you had to go through it again, what would you do differently?
Well, the first thing I would do is I would resign and move to Florida. I mean, that's the first thing I would do. Or better yet, I'd go to Melbourne, but only in the summertime, because I was there in the spring, and it was a lot colder than I ever thought it would be in the fall, in your fall, in April. We loved it. My wife and I fell in love with Melbourne, and she keeps telling me that we're going to move back there, and I'm like, so I'm gonna you know, scare up some work. But no, I mean, it's, you know, we work a process, and this is what we emergency management. We're not a normal department. We're separate and apart from everybody, and we work our process, and we worked our process for this job. We told everybody it was going to happen, and so I think in many ways we were lucky. I wouldn't change a lot about that, but I would try to, you know, maybe reach out to our sister systems and maybe pull them in a little sooner. Although we are talking to them. We have a you know, yet another call with them, but I think a lot of others.
Sorry, who was that, Kelly? Who was that?
So we have 5 major hospital systems in New York: Northwell, Mount Sinai, Montefiore, and Health and Hospitals Corporation. And so my counterparts, we all talk. We call it the 5 families, you know, and so, you know, I wish we could have worked together a little better. I guess there wasn't a lot of cooperation, not because we don't cooperate, but because we were all really
So
immersed
busy.
in our own job. Yeah.
Yeah. Okay. That's the end of the questions here online. So I'd like to sort of come to a conclusion by you leaving us with some key messages. So I'm thinking about crisis management planning. You know, I remember at our conference last year, we were thinking about crisis events that we could plan for. I mean, what would you take from this into a crisis management plan going forward?
So, you know, I've been through a lot of different types. From my first one was a terrorist event. When I was 8 years here at the City Office of Emergency Management, we had heat waves, we had a transit strike, we had tower cranes falling all over the city, we had hurricanes, and now a pandemic. So, you know, really, in so many ways, they're all the same. And really, it's just about how you bring people together inside that disaster zone and enable that effective action. And I'm not talking about how we operate. That process is the same across all, but it's not clear to others. And we are abysmally bad at communicating that process. These people here understand it because we have communicated well. This is what it's going to look like. This is what we're going to do. In fact, we had a executive tabletop exercise on the 8th of January with this very scenario. And we said, this is what it's going to look like. And so when it happened, you know, there's a lot less chaos in your minds because they're like, oh, those emergency management guys told me this was going to happen. So I think that really is the key, is how we as emergency managers communicate our process, so that when it does happen, people can really click into it and make those outcomes better in the process, because it's so ugly for many people. They struggle for so long until they finally, ultimately, they all get it together, but it's a painful few hours or days before they do. And we just try to eliminate that painful part and get to work.
So how different was the reality from the tabletop?
You know, only in the name. We said it was MERS coronavirus when it was SARS-CoV-2. But I'll send you the video. We made this, you know, we mocked it up. We threw them right in the jaw. I mean, these exercises, they're so poorly executed generally, but we execute them well, and we pretty much scare the heck out of people. But that's what it takes, because it's a scary world that we emergency managers come from, you know, and we try to show people that, and it motivates them in many cases to get ready, and that's our mission. Okay.
So do you want to please leave us with a couple of messages for people here? What would be, if you had to name the your three key learnings out of this experience?
I would say it's really one, and that is, you know, it's all going to be, everything's going to be all right. I think that's the key lesson at, you know, the capability that you all bring to the job. I mean, the people on this call and the people that I met in Melbourne and Sydney, I mean, you know, they're going to get through it. You've been through so much, just even recently. And, you know, what you went through with those early summer, that catastrophic wildfire season. So, you know, you'll get through it. And, you know, I guess it's hard to, it's hard to think that there's not anything you can do to stop it, right? How are you going to stop the outbreak? And I think everybody's doing everything they can. So, I don't know, it's a very bad message to leave with, but I think it's really, everything is going to be okay.
So be optimistic.
Yes.
Be optimistic.
Yes.
Okay, so I'll just say, is there any more questions on the Q&A? There's people here on the line that are from the police, from the fire service, from the ambulance service, those sort of emergency responders. What can you tell us about their role in this from New York?
Oh, I mean, they're holding it all together. I mean, oh my goodness. You know, I mean, the NYPD is, you know, they're what's holding this place together. And, you know, our EMS is through FDNY. So, you know, they're doing those 6,000, 7,000 runs a day. And, you know, these first responder agencies in New York are, you know, you can't say enough about them. I mean, they put their lives on the line every day, and it's all about service. You know, we're in a service business, and I think, you know, to me, it's the only way to really live your life is in service to others, and I think they exemplify that.
Okay. All right, we might bring this to an end. Somebody has written on the chat that it has been a privilege to have your insights. You look exhausted. It's the end of a long day. And a huge thank you for taking the time out to connect with us. People are just incredibly grateful to have your insight, and sharing is the best way. I mean, this is one of our strategic pillars at the Emergency Services Foundation, is to build the collective knowledge, and I think we've in some small way been able to do that today. So Kelly, thank you so much. And if anybody here on the line would be kind enough to just email me and provide some feedback about this, we'd be very grateful for that, for sure. Just so thank you very much, Kelly, and sleep well. Sleep well.
All right, take care.
Thank you.
Bye-bye.
Thank you.